Within my first clinical rotation as a graduate nurse, I came across multiple patients who, due to various risk factors, were diagnosed with chronic kidney disease and end-stage renal failure. As such, they attended regular dialysis appointments whilst they were admitted to our ward. The following study outlines the pathophysiology of chronic kidney disease, specifically that on the background of uncontrolled hypertension. I will briefly describe the clinical manifestations of end-stage renal failure and uremia. The study will also explain the different forms of and processes of dialysis available to an individual suffering from end-stage renal failure. Finally, it will outline some of the nursing implications for a patient, Mrs. A 70-year-old female diagnosed with chronic kidney disease on the background of unstable and poorly managed hypertension. Chronic kidney disease is defined by irreversible kidney damage or the irreversible loss of nephron. Nephrons are the functional units of the kidney where, through a complex process of filtration, reabsorption, and secretion, they are responsible for removing toxins and maintaining homeostasis. A nephron is constructed of the renal corpuscle, renal tubule, and associated capillaries. Blood is brought into the nephron through the efferent arteriole and enters the glomerulus, which is a network of capillaries surrounded by visceral epithelial cells, podocytes, that allow water and small solutes such as sodium chloride, potassium, bicarbonate, glucose, amino acids, creatine, and urea to filter out into the Bowman's capsule whilst preventing the filtration of large proteins such as albumin and red blood cells. Mesangial cells within the glomerular cavity support the capillaries and help regulate the filtration rate. Filtrate, collected in the Bowman's capsule, enters the proximal convoluted tubule, where the reabsorption of small solutes and secretion of uric acid and organic acid occurs. The loop of Henle is a continuation of the tubule, with ascending and descending limbs that travel through the medulla. Reabsorption of water occurs in the descending limb and reabsorption of sodium chloride in the ascending limb, leaving highly concentrated waste to travel through the distal convoluted tubule into the collecting duct and out into the renal pelvis. The causes. There are two main causes of chronic kidney disease: diabetes and hypertension. Others include glomerulonephritis, inherited diseases such as polycystic kidney disease, malformations, lupus, obstructions, and repeated urinary infections. For the purpose of this study, I'm going to explore hypertensive nephropathy as it relates to my patient Mrs. A. Hypertensive nephropathy is caused when the afferent arteriole tries to compensate for high systemic blood pressure by constricting its smooth muscles, restricting the blood flow into the glomerulus. So decreased flow equals decreased pressure. Over time, this results in hypertrophy of the smooth muscle cells. If high systemic blood pressure continues, trauma occurs to both endothelial cells and smooth muscle cells, leading to the excretion of cytokines, causing inflammation, fibrin, collagen, and lipids, causing haline arteriosclerosis, which is the hardening and thickening of arteries. The narrowing of the vessel leads to decreased blood flow to the glomerulus, to the point where glomerular atrophy and ischemia occurs. With the loss of a nephron causes glomerular hyperfiltration in the remaining functional nephrons, which results from and contributes to ongoing and repetitive glomerular injury. Glomerular filtration rate. As chronic kidney failure progresses, you will see a decrease in glomerular filtration rate, or GFR, which is the rate in which ultrafiltrate is formed by the glomerulus, and therefore is a direct measure of renal function. A normal functioning kidney has a GFR of 90 to 120 mL a minute per 1.73 squared meters of body surface area. The chronic kidney disease stages are as follows. Stage 1, kidney damage with normal or increased GFR of above 90 mL per minute per 1.73 meters squared. Stage 2, mild reduction in GFR, 60 to 89. Stage 3A, moderate reduction in GFR, 45 to 59. Stage 3B, moderate reduction in GFR, 30 to 44 mils. Stage 4, severe reduction in GFR, 15 to 29. or stage 5, where you're considered to have kidney failure where your GFR is below 15. A decreased GFR results in the decreased secretion of urea and other waste products. Increased levels of urea in the blood, also known as uremia, causes nausea, vomiting, loss of appetite, fatigue, neurological changes such as confusion and depression, as well as tremors and muscle cramps. Additionally, a low GFR can result in electrolyte imbalances. Decreased filtration results in reduced sodium filtration and ultimately water retention, causing increase in blood pressure and edema. Hyperkalemia is caused by potassium retention, resulting in muscle weakness, fibrillation, and ECG changes, such as a peak T wave, which is a cardiac event. Hypocalcemia is caused by the kidney's inability to produce the hormone calcitriol, which regulates the concentration of calcium and phosphorus into the blood, leading to a decrease of calcium reabsorption from the GIT and the kidneys. Low calcium levels in the blood, or hypocalcemia, stimulates the parathyroid gland to excessively excrete parathyroid hormone, which acts to increase calcium levels in the blood by drawing it out from the bones, which over time can lead to and cause osteoporosis and brittle bone disease. Dialysis. Dialysis is the artificial process of removing water, solutes, and toxins from the blood. Dialysis is indicated when a patient's GFR is 10 mL per minute per 1.73 meters squared of body surface area, and/or is experiencing the signs and symptoms of end-stage renal failure and uremia. There are two forms of dialysis: hemodialysis and peritoneal dialysis. Hemodialysis. Hemodialysis occurs outside of the body. It requires vascular access, a dialysis machine, and a dialyzer. Vascular access is gained through one of three options. Number 1. A fistula, which is surgically created in the wrist of your non-dominant hand. It is the joining of an artery to a vein, which increases blood flow to that vein. During dialysis, 2 needles are inserted into the fistula for the removal and return of blood. A fistula has the lowest risk of complications and provides the best long-term vascular access. A fistula takes time to begin working efficiently. The surgical procedure should be performed within a minimum of 6 weeks prior to the commencement of dialysis. When a fistula is working, you can feel and hear through a stethoscope a buzzing. 2. A graft is an artificial tube that connects the artery to a vein in either the arm or the leg. A graft is used when the veins are too small and delicate for a fistula to work. The dialysis needles are placed into the graft. The third option is a central venous catheter, which is used when a fistula or a graft is not possible, or the patient is waiting for the fistula to be ready, as it can be used immediately. However, a central venous catheter, if not managed carefully, it can increase the risk of infection and can become blocked. It is therefore not usually suitable for long-term use. The dialysis machine has 2 lines, one removing blood for cleansing and the second to return the blood. The machine pumps blood into and through the dialyzer, an artificial filter containing fine fibers with microscopic pores. Together, the dialyzer and dialysate act as an artificial kidney, drawing out solutes and toxins, creating waste, with the clean filtered blood returning to the patient. Hemodialysis is performed on an average of 3 times a week, and a single session can take 4 to 5 hours. Hemodialysis can take place either at home, where you or a support person is educated on how to manage your dialysis, at a satellite dialysis unit when the patient is well enough to receive and manage hemodialysis away from a hospital, or when the patient requires extra medical support, hemodialysis is performed on a hospital dialysis unit. Peritoneal dialysis. Alternatively to hemodialysis, a patient can receive peritoneal dialysis, a form of dialysis that occurs within the peritoneal cavity. Prior to commencement, a catheter is inserted through the abdomen and into the cavity. This catheter is then connected to a giving set, which drains and refills the space with dialysate. The peritoneal cavity acts as a reservoir for the dialysate. The dialysis solution absorbs waste product from the blood vessels through a semi-permeable membrane, the peritoneum, over a prescribed length of time. There are two types of peritoneal dialysis. 1. Continuous ambulatory peritoneal dialysis, or 2. Automated peritoneal dialysis. Continuous ambulatory peritoneal dialysis is performed 3 to 4 times a day, with the dialysate remaining in the peritoneal cavity for 4 to 6 plus hours at a time. The exchange of old and clean dialysis solution takes roughly 30 to 45 minutes, using gravity to drain and refill the solution. Automated peritoneal dialysis uses a machine, a cycler, to automatically perform the solution exchanges 3 to 5 times overnight whilst you sleep. The patient. So during my time working on the ward, I came across Mrs. A 70-year-old female diagnosed with chronic kidney disease on the background of unstable hypertension. During her stay on our ward, she attended hemodialysis 3 times a week, and due to her condition of her veins, she is receiving hemodialysis through a graft in her arm. On the ward, she presented confused and drowsy, with nausea and weight loss. On the ward, it was the responsibility of the healthcare team to manage the progression and the cause of her symptoms, alongside her regular dialysis treatment. Management included continuous monitoring and treatment of her hypertension. In order to slow progression of chronic kidney disease, it is suggested that you should aim to keep the patient's systolic blood pressure below 140. Mrs. A's blood pressure on admission ranged from 140 to 170 systolic and continued to fluctuate throughout her admission. The medical team prescribed Mrs. A antihypertensive medications, perindopril and telmisartan. Perindopril is an angiotensin-converting enzyme inhibitor, which prevents the conversion of angiotensin 1 to the vasoconstrictor peptide angiotensin 2. This reduces peripheral vascular resistance, reducing systemic blood pressure. Telmisartan is an angiotensin 2 receptor antagonist. It binds to the receptor, causing inhibition of angiotensin 2 on the vascular smooth muscle, again reducing vascular resistance and systemic blood pressure. Additionally, Mrs. A was prescribed calcitarol. Calcitarol is given to treat calcium deficiency, hypothyroidism, and metabolic bone disease. Calcitarol is the active form of vitamin D, which assists with regulating the concentration of calcium and phosphorus in the blood. As chronic kidney disease progresses, the kidneys lose their ability to convert vitamin D into its active form, which results in hypocalcemia and excessive excretion of the parathyroid hormone to draw calcium from the bones, causing osteoporosis. As previously stated, low urinary output and sodium and water retention causes hypertension and edema. Therefore, in addition to antihypertensive medications, Mrs. A was commenced on a low sodium diet and a 1 litre fluid restriction to reduce the amount of water retention occurring between each dialysis appointment. It is the responsibility of the nurse looking after Mrs. A to record all fluid intakes into a fluid balance chart and to perform daily or second daily weighs to monitor both fluid intake and retention. Nursing staff also perform daily assessments of her extremities, looking for any signs of edema. Further dietary restrictions were made by the dietitian in regard to her potassium intake. Reducing intake of potassium-rich foods such as bananas and spinach help prevent the effects of hyperkalemia and the occurrence of a cardiac event. It was also noted that Mrs. A's neurostatus and cognition was impaired as a side effect of uremia. She presents as drowsy and confused with occasional impulsive behaviour. It was therefore deemed that she was a high falls risk on admission. Mrs. A was placed on a proximate alarm and was positioned in a room within close proximity to the nurse's station for supervision, and all mobility required supervision from a member of the healthcare team. Frequent reassessment of her neurofunction was conducted for continuous management and intervention recommendations regarding the rest of her stay and her discharge planning. In conclusion, chronic kidney disease and end-stage renal failure occurs due to the irreversible loss of nephron. As a result, you will see a progressive decrease in glomerular filtration rate, the absorption and secretion of solutes, and a decreased excretion of waste. When a patient starts developing the signs and symptoms of uremia, electrolyte imbalances, and has a GFR of less than 10 mL per minute per 1.73 meters squared of body area, dialysis is considered. There are two types of dialysis. The first, hemodialysis, occurring outside the body. It requires vascular access, a dialysis machine, and a dialyzer. And the second, a peritoneal dialysis, which occurs within the peritoneal cavity using dialysate to draw waste through the peritoneum. In addition to dialysis, pharmaceutical interventions and lifestyle changes are implemented to manage and prevent symptoms of end-stage renal failure and chronic kidney disease.